perspective of multiparametric ultrasound liver imaging, because I believe that Professor Sporier also talked about hepatology and how ultrasound is involved in hepatology. So what is the concept of multiparametric ultrasound imaging? I touched on it earlier to say how you're emboldened as an imager to use all aspects of your ultrasound as you can possibly use to come to the correct diagnosis. And I encourage you to use everything you do have on your machine. A lot of the handheld machines or the ultrasound machines that are your iPhone or iPad can't possibly have all the software necessary for it, because it does require quite a bit of technical know-how to use it. But certainly all of your machines that you have in your clinics will have the multiparametric imaging available. Very often when you turn your machine on, you don't see anything there, but hidden in the machine is the software, and you have to present some money to the company and they give you a code and you turn it on and it's there. So it's not something that's difficult to attain. So always think when you're doing your ultrasound that you can do more with your ultrasound machine and use as much as you possibly can. And when you look at what you have available on your multiparametric imaging, the B mode, you can change the transducer frequencies, you can change the depth that you're imaging at, and the resolution you can get. You can use harmonic imaging, compound imaging, which is different methods to improve your imaging. You have broad bandwidth transducers where the frequencies go over a very broad range. You can use panoramic and wide field views, 3D and 4D images, and you can use echo texture analysis as well. And in Doppler ultrasound, not only do you have your spectral and color and power Doppler, but you've got the microvascular imaging now, the low flow techniques, and B-flow imaging on some of the machines. Strain elastography, shear wave elastography, point and 2D, and strain ratio you can use as well. Contrast enhanced ultrasound, the low MI imaging, high mechanical index imaging. You can flash and replenish your field of view by bursting all the bubbles. You can look at the time intensity curves, look at perfusion evaluation, and you can use and assess it for therapy. And you can use contrast to deliver gene therapy and chemotherapy as well. So all of this is done under ultrasound. And then you've got the more advanced techniques. You can fuse your ultrasound imaging with CT and MR on your machine, particularly if you're doing a biopsy of a lesion that's not clearly seen on ultrasound. And now you can quantify fat. This you probably heard about yesterday. And you can use it for needle tracking as well. So you have a phenomenal capability with your ultrasound. And all of this is done safely with no detriment to the patient at all, as opposed to other imaging techniques like CT, where the contrast is iodinated contrast, may result in renal impairment. Radiation, the younger you are, the higher the dose of radiation you get, because the less body fat you've got. MRI, patients refuse to have an MRI because they're claustrophobic. They won't go into it. They have a pacemaker, they can't go into it. They've got metal in their eye, they can't go into it. I've never had a refusal to come and lie on my ultrasound couch from any patient when invited. So you're already at an advantage from that. Gadolinium injection in contrast-enhanced MRI. It's retained in tissues. It's retained in the brain. Who knows what long-term effects are of this? Gadolinium is found in the rivers in North America now because it's excreted by the patient. And if you're giving gadolinium to your child, you don't know the long-term consequences of this. All of this you have to bear in mind when you've got the safest possible imaging technique. Use it to the full ability. And you use it in liver ultrasound, going from normal right over to cirrhotic, to use it for a procedure, and the follow-up all these procedures as well. So you've got a very powerful tool. B-mode has been around for a long time, and everyone who practices ultrasound, very often they do the liver ultrasound, particularly gastroenterologists, liver hepatologists, and radiologists. But not only you can look at the liver texture and things, you can also look at the vascular system with your B-mode and color Doppler. And it's very easy to differentiate a lesion from in a non-cirrhotic liver to obstruction in the biliary tree, infiltrative lesions, and the regularity of the liver and the size of the liver. All is very straightforward. And you have various appearances that you will see, and you'll be able to make quite substantial diagnosis of what's going on in those patients, from fatty livers to end-stage cirrhosis, in a point of care fashion in many ways, as we've heard earlier on, looking for free fluid and ascites in the abdomen. It just saves you so much time when you know you can do it straight at the bedside. And I would suggest also in the future that point of care ultrasound and liver ultrasound may evolve to be more comprehensive than it is at the moment in primary care practice. With vascular imaging, we've known for a long time, and I relate this to liver transplantation, that we do a largest liver transplant unit in Europe in King's College Hospital, and you can pick up and identify the hepatic artery in different stages, immediately post-operatively, where there's a tardis parvis waveform, and in cirrhosis, where you've got this high resistance index in the patient, indicating end-stream issues. And you can watch and see and look at portal vein reversal with a hyperdynamic hepatic artery, implying that you've got chronic liver disease here, adding to your ability to make a diagnosis. And you can see portal vein thrombosis, changes in the hepatic artery with fulminant hepatic failure, that very high resistance hepatic artery, because you cannot get blood into the liver, it's so edematous, gives you a clue as to the prognosis and the severity of the underlying disease. And you can also look at the hepatic veins, looking at the changes in the hepatic veins from the normal patient to the one patient with hyperdynamic congestive cardiac failure and with very bad cirrhotic liver, where there's no compliance to the liver at all. All of this gives you further information. We use contrast-enhanced ultrasound, and the green dot here signifies where the hepatic artery is in the post-transplant patient. And you have the opportunity there to pick out the artery in about 5 or 6 seconds before the portal vein comes through, to show that that artery is patent. And this is important, because if you lose your hepatic artery, you lose the graft, and it's a disaster for the patient. But you can revascularize, and you can do it early. You can do this at the bedside of the patient in the intensive care unit. There's no need to bring it down for other imaging. But microvascular imaging does this just as well. Sorry. It's not working, but it was working a minute ago. Sorry about it. But microvascular imaging allows you to pick up the hepatic artery as well. What about using it for your focal liver lesions? The most common lesion you'll see in a primary care patient who is having an ultrasound examination for vague symptoms, or maybe slightly abnormal liver function test, you find a focal lesion, 90% of the time it's benign. So you want to be able to say to the patient, when you find that lesion, and they know you've found a lesion because you're scanning the patient, you're looking at the patient, you're chatting to them, suddenly you stop. And you're concentrating on your screen and looking very hard. Of course, the patient knows you found something. What are you hiding it from? But you'll be able to say to the patient, well, I think this is a benign lesion. Maybe it's a hemangioma. But if I give you contrast now, and this is what we do in our practice in radiology, I can tell you for sure that it's a benign lesion. You don't have to wait 3 months for an MRI, CT, and a physician's hepatologist appointment. In the meantime, they've gone on a world cruise, they've sold their house because they think they're going to die. You stop all that, okay? So this is downstream costs you're saving for the patient. And it's very simple to make this diagnosis, because classically the hemangioma is that echogenic, sometimes quite large lesion, but you're looking at this globular enhancement as it comes through from the periphery with the contrast and works its way down. Why is contrast enhanced ultrasound better than any other imaging for this? Because not only you're not irradiating the patient, you're watching it in real time. So you are making the diagnosis, watching and storing it on video and assessing every frame. Whereas if you're looking at the CT or the MR, you are presented with an image by the technician at the time he or she thinks it's most appropriate to make that image and give it to you. So you are making an interpretation on one image that you're not seeing all of it. And so this is the difference between your contrast-enhanced ultrasound and every other imaging modality. But look at this now. This is a very abnormal looking hemangioma, but within 25 seconds you have the diagnosis and you can tell the patient you have a benign hemangioma. It's quite big, but it's not going to kill you. And this is very important. And the same, and this is just to give you an indication of it. That same patient went on to have a CT scan. So we've just watched this for 1 minute after injection of contrast, which is very safe. The patients had 4 different CTs: baseline, arterial phase, portal phase, and late phase. 4 lots of radiation through the abdomen, 80 mils of contrast to that patient. I've given the patient 2.4 mils, and an ultrasound in 1 minute gives the same diagnosis. Ask the patient what they prefer for the diagnosis of their focal liver lesion. I think we know the answer, and it's so accurate. And the same with the focal nodular hyperplasia, a much rarer liver issue, but when you do see it, you can make the diagnosis, because in the arterial phase, you're looking for that star appearance, that spoke wheel as it comes out and then becomes hyper-enhancing and doesn't wash out. And this is pathognomonic. Again, you will not see this image on any other modality like CT or MR because it happens so quickly. So let me show you this image of a focal nodular hyperplasia. And you can see here it is on the B mode, here it's on the color Doppler. But that appearance only lasted 3 seconds. Unless your CT catches it at that time, you will not see that. But this is pathognomonic of a focal nodular hyperplasia. So in the hands of ultrasound, you are better than other imaging modalities when you can see it as clearly as this. And the same also for hepatic adenomas, though there are some difficulties with hepatic adenomas because you may have different histology, and 1 or 2 of the more malignant potential histology actually washes out. But it has a different pattern of enhancement where it comes in from the periphery, but it remains hyper-enhancing. It doesn't wash out in the late phase. So if you're starting to see washout after 1, 2, or 3 minutes, you're dealing with something that's malignant here. An abscess is very easy to pick up on contrast-enhanced ultrasound when you have a focal benign lesion. Once you put in the contrast, you can see the septations. You can also see the areas where the pus are, which has got no vascularity at all. And why is that important? Because you know then you can do a percutaneous drainage of that patient safely because you know there's fluid in that area. And if it's very septated, you know you're not going to drain all of that abscess. If you've got multiple abscesses, you can also drain one of those abscesses, and down the drain itself put a small amount of contrast. 1 drop in 20 mils is all you need of the contrast. Inject it acid contrast and see whether those abscess cavities are draining with each other. And you know you don't need to put more than 1 drain in. But it gives you the diagnosis almost immediately. We've also used this in focal fatty sparing. You will see more focal fatty sparing in your practice, particularly in point of care if you're looking at livers, because focal fatty infiltration and focal fatty sparing in the presence of a fatty liver is something that's part of the obesity epidemic that's occurring at the moment. And we see this in children. We have a very big hepatic patient population, including children. And we use contrast-enhanced ultrasound in those indeterminate lesions in the children if we think it's focal fatty sparing to confirm that. And during our investigations over a number of years looking at focal fatty sparing using contrast-enhanced ultrasound, we've actually shown that focal fatty sparing behaves differently from focal fatty infiltration in that there's a delayed enhancement in focal fatty sparing, and it is noticeable. And we've done this with time intensity curves on a whole cohort of patients. But it doesn't matter. It is still focal fatty sparing, but it does behave a little bit differently. And this was published in the Journal of Ultrasound in Medicine. Malignant lesions in primary care you will not see so much unless they're actually an oncology patient with a known primary. Then you have to be a little bit more suspicious. But with contrast-enhanced ultrasound, this is very clear that the metastases may or may not be hypervascular, but they will wash out. That contrast will become black within 30-40 seconds. It's very rapid and very clear. And it's a clear diagnosis to make, and you can then triage the patient appropriately for further management. So it's a very useful thing as well. In cholangiocarcinoma, the hallmark here is again peripheral vascularization and washout. Cholangiocarcinomas may be very difficult to see on a B-mode ultrasound because they can blend in with the liver. But what they do, they're intrahepatic, is cause bile duct blockage and dilatation. And this is where adding your contrast gives you that clear delineation of bile duct obstruction and dilatation. Hepatocellular carcinoma is a bit more difficult, and I'll do a little bit more on this because you are relying on a patient having underlying liver disease, chronic liver disease, usually a hepatitis B or C. And we've got about 9,000 hepatitis patients in our clinic at King's. So we do a lot of surveillance ultrasound, and we do a contrast-enhanced ultrasound on newly seen nodules that appear in the liver to see if we can stop, again, downstream costs of the CT and MRI. And the hallmark of hepatocellular carcinoma is hyperenhancement in the vascular phase and then late washout. The washout of the contrast is dependent on the differentiation of the hepatocellular carcinoma. So a well-differentiated hepatocellular carcinoma takes a long time to wash out. A poorly differentiated and highly malignant lesion washes out quickly. And this again affects management as to whether or not these patients will have a chemoembolization or resection or be listed for transplantation. And very briefly, in the contrast guidelines issued by EFSUMB, you have all of this detailed, so it's very easily obtainable. Now, looking at the HCC and the recommendations for it is not, if you do find a focal liver lesion and you suspect it's HCC or malignant, you still do need cross-sectional imaging for staging. But what you're preventing is those clearly benign lesions going on for further imaging. So this is the appearances you would get with a focal HCC hyperenhancement, and you can often see the artery supplying that area, and you only see this if you catch it appropriately on the CT or in angiography. And what happens in the late phase, it becomes black, it washes out, and this is an HCC. And the College of Radiologists has detailed, and there's no point in taking this in too much to tell you how malignant or benign that lesion is depending on your vascularization. So this is arterial hyperenhancement, and this is washout. So if it's arterialized and washes out, then it's an HCC, and it's classified immediately as that. And this works very well. We just finished a multi-center study with 650 patients with CT and MR correlation on this particular thing. And contrast-enhanced ultrasound is as good as CT in telling you whether or not it's a benign or malignant lesion in cirrhotic patients. Very quickly, I'll jump on now because I know you've had this shear wave elastography in the liver and how important it is for evaluation of the chronic liver disease. And this is one area of point of care where it will be very useful. We've heard a lot about transient elastography, and it's well established and has been around for 20 over years, but it is not, and is regarded as a gold standard, but it's probably not going to be the standard of care that you will use in the future for fibrosis of the liver. As a radiologist, you are horrified that you're making a measurement from something you can't see, because the transient elastography, you just put the probe there, press a button, you don't see where it is. Whereas as an imager or a radiologist, you want to see where you're putting that measurement box. Strain elastography and shear wave, point and 2D shear wave elastography. Point is the more established technique with Siemens and ARFI, and this is in all the various guidelines for it. You're plotting up against the fibrotic level of the liver, and this is usually the METAVIR score, and it's graded 0, 1, 2, 3, 4, where 4 is cirrhosis. But at King's College Hospital, we are different. We use the different scoring method, the Ishak scoring method for level of fibrosis, which has got 6 scores. And so we've had to set up our own measurements. So we did this in a particular study looking at liver biopsy against ARFI, and we had over 400 patients in the study. And this showed that ARFI was as good as other liver methods, and we got a cutoff point for significant and severe fibrosis. And of course, you now 2D is coming through for measurement of fibrosis, and this is a slightly different. You don't have to make as many repeated measurements as you would do with point shear wave elastography. But there are limitations to shear wave elastography. Patient factors are involved, obesity, male or female, different machines are different, and there is much overlap between the mild F1, F2, F3 levels. But where it's very useful, and this is where it will be useful in point of care, is it's very clear that the patient is cirrhotic or the patient is normal. And diagnosing normal is as important as diagnosing abnormal in your patients. And this is where it's very good. The newer kid on the block, and this is coming through very quickly, and this in point of care ultrasound will be important, is quantification of fat. Previously, you just have a look and see, and you'd measure, yes, it's very fatty, I think it's moderate, I think it's mild. Let's see you next time, and I still think it's moderate, maybe mild, could be severe, but this is of no use clinically. You want this quantified. And you're looking at liver kidney contrast, vessel blurring, beam attenuation, and whether you can see the gallbladder or not. And this is now changing, because you're looking at different things, and you're looking at the quality of the ultrasound in attenuation, backscatter, and there's another method, and speed of sound, looking at fat quantification. And of all the methods, speed of sound is actually probably the most accurate, but the most difficult to get into clinical practice. But all the machines have these measurements, and so you have a ratio that you can measure of the hepatorenal index, and this is useful because it's simple to perform, and you can get a quantification. Yes, it's 3 times, it's 4 times more reflective to liver than the kidney, and this is you can use in the longitudinal management of fatty liver disease. But beware, if you've got chronic renal disease, you cannot use this. But the tissue attenuation and backscatter is coming through. This is a Samsung version of this, but the most important area is to try and relate it to the standards of fat measurement. Previously, the standards of fat measurement would be liver biopsy, but MRI, MDPP, is now used as the gold standard for measuring fat content in the liver. But ultrasound machines, and this is particularly true of the Siemens machine, which has a technique where it has a box with 15 measurements of your elastography and fat quantification, combining attenuation and backscatter to give you a fat percentage. And this will probably be the future of your point of care imaging of liver disease in the clinic, that you're able to in 10 seconds diagnose whether or not that patient is fibrotic and how much the fat content is in that liver. So you have these tools coming through. The one thing that we haven't got just yet is indirect measurement of portal hypertension. The most accurate measurement of portal hypertension is hepatic venous pressure measurements, which is truly invasive. So you want something that you'll be able to tell that the patient has got portal hypertension or not. Portal hypertension you can pick up by looking for portosystemic collaterals, but this is of no use because it's already developed and advanced. But there is a technique that's now coming through using contrast-enhanced ultrasound by using subharmonic pressure estimates from an ultrasound contrast agent. It's used at the moment in a research mode, but you can look at the microbubbles in the portal vein and see how much that pressure affects that portal vein. So what I've shown you is that you have now, and you're almost complete, having a one-stop imaging technique for your patients with liver disease, which tells you everything. With one more thing is that portal hypertension, and you've got a complete assessment on ultrasound on that patient. You've got your B mode on the texture of the liver, irregularity of the surface, the size of the liver, You have your color Doppler, microvascular imaging, spectral Doppler to look at the portal vein, hepatic artery, and hepatic veins, portal vein. You have focal lesions you see on B mode. You can use contrast to immediately classify that lesion into benign or malignant. You have tissue elastography. You can tell whether or not there's fibrosis accurately. You can tell if it's cirrhotic or normal. You now have a possibility of measuring fat quantification, and in the next year or two, this will become incredibly easy on your machines. You'll have one box which tells you, and results that tells you in 10 seconds the fibrosis and the percentage of fat in the liver. You have the possibility of looking at portal hypertension by measuring spleen size and looking at collaterals, but in the future, you'll have a non-invasive method of looking at portal hypertension. This is the true one-stop, non-invasive technique for looking at chronic liver disease, and most of it is you can use it in point of care. Certainly, the fat quantification, fibrosis, B mode, and color Doppler is all there. Thank you.
Hello, I'm happy to be again with you in this morning. And what I like to cover maybe is not the part that you like very much, digestive tube, but we'll try to show you which are the good points and weak points of ultrasound for examination of the digestive tube. I published my first book of transabdominal ultrasound of the digestive tube long time ago. Then I'm a little focused on this. And evaluation of digestive tube is a challenge for people performing ultrasound. Usually we hate the gas inside the digestive tube because we are not able to see some structure that we like to see. But with some experience in ultrasound in the second step saying so, you will see some digestive structure and you will be happy that you can have some nice diagnosis. For the visualization of digestive tube, we must have two probes. This is the weak point, saying so. You must have at least two, and this is multi-frequency convex probe, classical probe for the abdomen, and second, a linear multi-frequency probe, and this is necessary to see the wall of digestive structure. Okay, but again, we speak here about clinical ultrasound. Then we must start from history of the patient, palpation maybe if we feel a mass or something, then abdominal ultrasound, then we can go to digestive structure, and if we find something, always we must make an upper or a lower endoscopy. For me, like gastroenterology is very easy because I can perform immediately. Maybe for you, but you can refer this patient and you can have nice diagnosis. And here in this slide, you can see maybe which are the usual structure that can be seen by transabdominal ultrasound. And this esophageal junction, antrum, I showed you yesterday how simple it is to see to the antrum. Then we look to terminal ileum and the sigmoid colon because it's a fixed part. More difficult is to see upper esophagus than the vertical part of the stomach, duodenum, to see entire small bowel and all the colon. Normally the digestive tube have 6 layers and the thickness of the wall is between 2 and 5 millimeter, and this is depend about which part of digestive tube. And you can see here which are these layers. Don't matter too much, but you can see sometime this structure. Not always, but sometimes you can see these all 5 layers. You can see in this image is the stomach, the antrum here, and we can see here the anterior wall with the 5 layer. And yes, there was a question about the posterior layer of the stomach. It's a little more difficult, especially if the patient is not in fasting condition, because the food don't let us to see this part. Okay, then we start with the examination of the esophageal junction, and for this we apply the probe in epigastric, very high place of the epigastrum, and behind the left lobe of the liver we can see this structure. Then it's the esophageal junction. Here is the heart. Okay, then this is the diaphragm, and this is the abdominal esophagus, saying so. And here is the stomach. Okay, here's the stomach with some water. If you like to see very well the stomach, we give 500 ml of still water or maybe apple juice. I don't know exactly why apple juice give a very nice image, but the literature says so. And then we stay usually 8-10 minutes. Otherwise, we'll have a lot of bubble that are swallowed, and then we can see quite nicely the antrum and a part of the body of the stomach. The body is difficult to be seen because the gas go in this part usually, and we must give a lot of water to see this vertical part of the stomach. Okay, then we have here an image with linear probe with the normal movement of the intestinal loop. When you see this, you are very happy how nice method you have in your hand to see the movement of the bowel. Now Now we look again with linear probe to the terminal ileum. Here is the image of the terminal ileum, and we have here the image endoscopically image. We are in the cecum, and then we go and we enter in the terminal ileum. Okay, then we can see quite the same that we can see by endoscopy in this image. Okay, in the past we used to have hydrosonography of the colon, making an enema of the patient, putting water in the colon and looking to the colon. We don't use in this moment. It's a little difficult to make this examination because the patient is not able to keep too much the enema. But in the previous time we use sometimes this method. Okay, which are the pathological findings that we can have with this gastrointestinal ultrasound use? We can have suspicion of delayed gastric emptying, suspicion of occlusion, evaluation and diagnosis and follow-up of Crohn's diseases, evaluation of extension ulcerative colitis, and diagnosis of acute appendicitis and diverticulitis. Then it's quite an easy diagnosis. You have a fasting patient, they coming vomiting, and you put the probe and you can see the stomach. It's a very simple section. We are in the epigastrum and we can see the stomach that is full with the content. That is semi-solid content. You can see the wall here, posterior and anterior wall of the stomach. Then this is a very simple diagnosis. You can make exercise for this, looking to the patient not in fasting condition like yesterday. Yesterday was a lot of people with the food in the stomach. Okay, but if the patient is fasting for some hour, 10 hours or something, and you will find this image, you know that it's a gastric delayed emptying of the stomach. We can look, try to look to the size of the wall, and you can have a suspicion of benign or a malign delayed emptying, because if it's a cancer, you will see the wall of the stomach that is enlarged. Okay, then other diagnosis is the occlusion of the small bowel. In this condition, we can see the loop that are larger than 3 centimeters in size, and here the content is semi-solid content in the bowel. We can follow this enlarged bowel loop. You can see the movement of the content of the bowel. Okay. Sometimes we can find only fluid inside the bowel loop. You can see a very enlarged bowel loops. Look here. These are full of fluid. You can see vulva connivente here too. Then usually we like to have an X-ray examination of the abdomen to see what? The hydroaeric level. In ultrasound we can see very well the hydric level and not the aeric level. Okay, you can see here the movement of the content and very active bowel movement. Something about sensitivity of ultrasound, and I took here two very old paper. Why? To show you that 20 years ago ultrasound with the old machine had a good value for occlusion. And look here, diagnosis of occlusion have a sensitivity of 83 with quite a high specificity. When we see the image, we are quite sure that it's an occlusion. Sometimes we can see the place, the tumor that make this occlusion, or something that give this occlusion, and sensitivity here is 70–85%. And it's very simple by ultrasound to know if this occlusion is a dynamic or paralytic occlusion, because we see the loops that are moving or are not moving. Okay, then we go to Crohn's diseases. Okay, then we have here some ultrasound examination. This is with linear probe, this is with convex probe. What you can see, very enlarged wall. Then here is approximately 10 millimeter in of the wall, anterior and posterior wall, and the air inside, the white one. Okay, and we have here the aspect by in endoscopy of Crohn's disease with a lot of ulceration in the colon. Then where to search? We search this in a patient with some symptoms like diarrhea, some weight loss, and some pain, abdominal pain, and we look along the colon to find such a image. This is so-called target lesion or kidney-like image that we can find here and here. And what you can see here is the disappearance of the stratification. Usually we see some stratification, not very often all 5 layer. We see some layer, but here is totally disappeared this stratification. We have here other 2 image of 10 ileum Crohn's diseases, and these are both by linear probe. Okay, here we can see some stratification, but not very much. This is a typical sign of in Crohn's disappearance of stratification and very enlarged wall, and this is a typical aspect, endoscopical aspect of the terminal ileum in Crohn's diseases. Okay, then here look, following the bowel, we arrive in an area where stratification is still preserved, partially still preserved, and we can see here this muscularis propria and this is submucosa, the white one. In the middle is mucosa and the lumen of the terminal ileum. Here's a case of Crohn's disease with occlusion. We can see very large bowel loop. We can see the content here and some small amount of inflammatory fluid here. And we have here again a Crohn's disease with occlusion. You can see very large bowel loop and some fluid here, and the movement of the bowel that try to overpass the stenotic area. Again, a very old paper to show you how good is the method, and I give you this old paper to know that not the machine make this, but you experience make to have a diagnosis. And look here, was between 92 and 99, and look to the sensitivity for good team. This is 98 sensitivity of the Italian group of Marconi, and the specificity is very high, more than 85, going 97 of in such case of diagnosis of ileal Crohn's disease, where the diagnosis is more simple. Okay, we go to ulcerative colitis. How to use this in a patient with bloody diarrhea? Always I look for the sigmoid. Why for sigmoid? Because sigmoid is quite simple to be seen. It's in a fixed position. You put a probe there, you'll find very simple the sigmoid. And if you can see this interesting aspect here, it's very simple to be seen. This is stratification that is kept here, and we can see submucosa, this white one. White is the submucosa here that is enlarged. Then we can see muscularis propria, submucosa, and mucosa here. Then this is anterior wall and this is a posterior wall. And this is the endoscopical aspect. For endoscopists, it's a very simple diagnosis of ulcerative colitis. Then if you find such image, have in mind will be ulcerative colitis. You can follow the colon, trying to find how long it's affected area, because we know that in ulcerative colitis you can have proctitis or left colitis or pancolitis. Then we can know before endoscopy how long is the affected area of the colon. Okay. Some occasional findings, like here, the patient with dysphagia, we look here and we find a mass here that contain inside air and is high suspicion of cancer of esophageal junction. We send for endoscopy and it will be a confirmation of our diagnosis. quite rare we can see such lesions that are a lipoma or a leiomyoma in the stomach. This is with some water and occasionally finding. Looking, we found something that seemed to be in the stomach, and to give some water, and we have these two images. This is a very nice image of a gastric polyp. Look, we found this lesion in the stomach. We gave some water to have a better view of the lesion. Then we perform endoscopy to see this large, 4 centimeter polyp, and we can see here, the pediculum, despite this seem to be unsessile, was finally and pediculated, and the pedicle is here. It's a occasional discover findings, but it's a nice image to show you. Okay, then these are incidental occasional findings. Patient with some weight loss. You look for the stomach. You find the antrum that is a large anterior posterior wall, and this was confirmed to be gastric cancer. Then antral gastric cancer is not very difficult to be seen. Sure, we don't look specially for this, but performing ultrasound in our patient with some digestive symptom, we can have this image. If we are some suspicion, again give some water, 500, 700 ml of water, and you will see these antral wall that are large. Other case, the same diagnosis. Look here, it's no water, then is the air inside. This is the anterior wall of the stomach that is somewhere, I believe, 12 millimeter or something. Then this is antral cancer here. Again, need confirmation, but endoscopy. Other typical gastric cancer in the antrum. Look here to the wall. Here we gave some water to be sure that it's real. We have this modification. We can have, this is a transversal section. We can make a longitudinal one, and we'll see the circumferential enlargement of the wall. Sometimes we can find a cancer in the colon. Here it's ascending colon. This is kidney-like sign. Here is the real kidney, and below this we find a mass that is with air inside. This is a target sign, or a kidney-like sign, and this was confirmed to be a cancer in the ascending colon. Here in other case, was a male, 62 years old, that came with anemia, and to the palpation of the abdomen, I feel some mass there. I put the probe on the mass, and it's a kidney-like structure. You can believe it's a kidney because it seems like a kidney. Here is the air inside, and this is the wall that is very much enlarged, maybe 2 centimeters in size. And endoscopy, colonoscopy confirmed the diagnosis of neoplasia, very typical endoscopic, colonoscopic aspect of neoplasia of the colon. Okay, other indication, diagnosis of acute appendicitis, but I like to underline a lot, because here the experience is necessary on this topic, and the linear probe is mandatory. I don't make emergency examination for 20 years or something. Then you must be trained for this, especially the emergency doctor, the people that make a lot of duty in the night, maybe the surgeon. They can have experience because they make examination, and then they go in the operating room and they look and have a confirmation for this. Then for appendicitis, because we discussed many times with my friend in gastroenterology field, usually the professor lost a little experience with appendicitis because we don't make emergency. But the young doctor can be very much trained, and the accuracy of this method for trained group is more than 90-95%. And a very good method, especially the specificity. When you can see some sign of appendicitis, then it's appendicitis. Okay, the other diagnosis that is very good for emergency examination is diagnosis of acute diverticulitis. I say for you that acute diverticulitis is like an appendicitis, but on the left. The patient had quite this symptom, pain on the left, exactly in the left fossa, and then it's very simple because we put the leukocytosis and others, and we put the probe exactly where the pain is, or where the patient say, I feel pain there, and have we can have such an image. This is the colon, this is a linear probe, and here is the colon. Okay, and this is a inflamed diverticula. Interesting, without air inside. Usually inside the diverticula, such diverticula, we have air inside. Okay, this is a case of acute appendicitis with some fluid and large size of the appendix, usually more than 6 millimeter in size. Is high suspicion. We can see coprolites. Then we have some sign of this. Okay, if you like to learn about gastrointestinal ultrasound, we, together with Christian Jensen, other good friend of us, we have a lot of position paper, and these are 7 paper or guideline and recommendation guideline. The first one is about how to make examination. You can have this paper from the EFSUMB site. Okay, then is the first part, examination and normal findings. Then you can have this about emergency, intestinal emergency, and you can have this in acute appendicitis or diverticulitis. Then you have all that you need for your activity. And finally, there are 7 guideline recommendation, and you can have all these. Read please this paper, this guideline, if you like to learn how to make examination and what you can obtain. And if you practice, you can be good in this field. If you look quite rare for such pathology, it would be quite difficult to have this diagnosis. And then, from the point of view of a clinician, I believe it's very important that we have, including for the digestive tube, this third hand or third eyes, because usually simple doctor, what they do, palpation or something, but we can look inside, and this is wonderful. And if you find a lesion, always you must send to have an endoscopic evaluation for this confirmation. Thank you very much. This was experience last year, okay, and we are happy because vast majority of us was without mask in today. Thank you very much. And if you have question, please.
Good afternoon, ladies and gentlemen. The topic of the last lecture is thoracic ultrasound. The thing is that before we start, we need to somehow understand what is hidden behind the phrase thoracic ultrasonography. Well, let's try to look on this part of sonography, dividing it into three parts: chest wall, supraclavicular fossa, and lung sonography. So those three parts of thoracic ultrasonography: chest wall, supraclavicular fossa, and lung sonography. The chest wall, there are a number of pathology we might find in a chest wall. The good thing is that those pathology have a rather simple examination technique, just to put the probe on it, yeah? And the bad thing is that sometimes the differential diagnosis, sonographic differential diagnosis, might be a little bit challenging. The second part of thoracic ultrasonography, supraclavicular fossa, the good thing is that the examination technique is quite simple. How about the differential diagnosis? Is it simple? I let myself to put a question mark over there, which we're gonna explore in a minute. And the lung ultrasound, the good thing is, it's a rather simple examination technique, but remember that we want to examine all the surface areas, zones, whatever it's called, of the lungs, not only upper blue point and lower blue point. And it's simple diagnostic differential diagnosis, but only when you consider the sonographic image in a light of medical history of the patients and physical examination. So, starting with the chest wall, one of the most common lesions, one of the most common findings you may find in a patient on a chest wall. Doctor, I've got a lump here. You put a probe on and you see the lipoma. Lipoma, it is benign lesions. As we can see, the spectrum of sonographic images might be different. Well, it's well defined, it's soft, you can easily press the lesions. It's isoechoic, it might be a little bit even hyperechoic, but it's the most common. You may find in the lipoma horizontal hyperechoic lines, which we can see over there. Staying in the chest wall, another situation that you may meet, it's broken rib. Doctor, I had a fall, somebody hit me, and I have a pain over there. So what are you doing? You're just putting a probe where the pain is. And now you can see that there is a rib and there is discontinuation of the rib, and the rib was broken. So you are the primary physician. You have a patient who have a fall, for example, and you already found a broken rib. So what you are going to do next? You are going a little bit deeper with your linear transducer. You want to see if there is, for example, pneumothorax, if there are any signs of this trauma more inside in the chest, which we're gonna continue in a minute. You are sitting in your department, and somebody is coming, a patient, male patient is coming to you, because as we've already said, the breast problems are not only in women's, also the men's have problem with breast. Well, you see such a breast in a man, it's a little bit red, it's tough, tender, we would say. And what's your clinical problem? Is it just the inflammation of soft tissue, which we can try to cure with antibiotics, or if there an abscess inside? So what we are doing? We're putting a probe on it, and what we can find, that there is an abscess. The patient needs to go to the surgery room to cure the abscess. The breast, we're staying in a breast, but we have some space to talk about a breast in male. You've got a patient and you put a probe and you see such image. This is gynecomastia. And the thing is, how old is the patient? Because we know that between 13 and 16 years of age, the gynecomastia might be physiological. But if it comes up that the 10-year-old boy will come to you with a lump in the nipple and you put a probe on it and you will see such image, you are starting to be worried. If the man who is over 16, 17 will come to you with such image, you are always starting to be worried. Why and where would you put a probe in this examination? What you would examine? We know that it's gynecomastia. We know that it's imaging in a male. Let's say he is 10 years old or 17 years old. It's not the time of physiological gynecomastia. We would put a probe to testicles. Why? Because he might have tumor that is producing hormones which are changing his breast images. And the initial diagnosis, the real problem might be in testes. It sounds crazy that we have a topic about thoracic sonography, and I am trying to encourage you to examine testes. Yeah? But this is how it works. This is how modern sonography in primary physician examination room works. This is what you came here to hear. But we've already had gynecomastia. If the boy is between 13 and 16 years of age, I see gynecomastia, I always put a probe to the testis to make sure that there is no tumor in a testis. This is how we join in PoCUS different parts of the body during one examination. The thing is that when we are starting the PoCUS examination, we know where we are starting, but we don't really know when we will be finishing. It might be finishing in a testis, for example. We had a patient who is adult patient and who come to us and he said that, well, I have few lumps on my chest wall, doctor. So the skin is okay. You touch the lumps, they are quite hard. You put a probe on it, and the first question is it similar to a lipoma? No. The second question is there any vasculation in this area? No. The third question is it soft, tender? Even if you don't have elastography, you can't press the lesion. So, what you think that it might happen? 3 lesions, chest wall, tuft, heart. But we need to have one extra thing. We need to have a medical history. What's your problem? What has changed in your life in the last time? Well, doctor, I have a weak legs. Do you know the syndrome of weak legs? The standing, walking is very difficult for me. We have 2 points. We have some kind of lesions which we don't know looking at the image, and we have a weak legs. And we need to, in our head, join those 2 things. So, do you think it might be a neoplastic disease? It might be, because the lesions that we have in the chest wall are metastasis. And where is the primary focus? Where we'll be looking for the primary focus? Lambert-Eaton syndrome, paraneoplastic syndrome with a weak legs, which is very characteristic for lung cancer. And this is about the sonography. The image will not tell you that it's the metastasis of lung cancer, and I will not tell it to you, yeah? But we join in our head sonographic image, medical history, and a little bit of the knowledge that sometimes the lung cancer might start to present with Lambert-Eaton syndrome when you have weak legs. Let's leave the chest wall for a while and let's go to the supraclavicular fossa. The examination technique is really very simple. You know what is simple in supraclavicular fossa? That the proper image is very easy to differentiate between pathological image. But what kind of pathologies we can find in supraclavicular fossa? Well, we may find pathological lymph nodes. If you see the pathological lymph nodes on the right-hand side and left-hand side, try to think about non-Hodgkin lymphoma or try to think about Hodgkin disease. You will not differentiate those two situations in point of care examination, but you know when those conditions required further diagnosis. This is my patient, a male who came with such lymph nodes. The final diagnosis was non-Hodgkin lymphoma. But the thing is that if you have a patient who has a pathological lymph nodes on the right supraclavicular fossa, so we're thinking on the right hand side about metastasis from lung, breast, head, neck. But it's pretty easy at the moment. It's getting to be more difficult when the patient is coming to us and we are finding pathological lymph node on left side in the supraclavicular fossa. Of course, lung, breast, but because of thoracic duct, we need to go below the diaphragm. Yes? So we need to go to the abdomen looking for a primary focus of the neoplastic disease, and we need to go to testes. Yes, and this is how it works. I'm talking about thoracic sonography, encouraging you to go to the testes, answering the question if the family doctor can go to the scrotal sonographic examination. Definitely she has to, as Professor Sitko said, if he knows what he are doing. But the thing is that the main limitation of PoCUS is not equipment, it's your head, what we have in our heads. It's like a brain map. It's like sometimes you're looking at the map of the tube, for example, in Vienna. You know how many different connections you can make. And the same you're doing with sonography. It's just about making clinical relevant connections. It may happen that you may have a patient like that who has on the right hand side, this is a lady, pathological lymph nodes. You look at those nodes, you know that those are pathological lymph nodes. But you examine the chest and you examine the lung and you can see proper image. And it may happen like that such person will have a lung cancer, because the lung cancer, if it does not changing the sonographic image in the chest wall, will give you the proper image. That's why sonographic examination, it's not a screening examination for a lung cancer. And through the chest wall, supraclavicular fossa, let's go to the chest, to the lung sonography. And starting at the very beginning, let's remember that lung sonography, because our first connection might be blue protocol, the second connection might be COVID-19, actually lung sonography, it's not only about blue protocol and COVID-19. Of course, we had a lot of patients with COVID-19, interstitial pneumonia, when we had this pandemic on a top level in Poland. I had my personal challenge to find all the patients with sonographic image of interstitial pneumonia and negative PCR test, false negative PCR test, which helped me to differentiate it because between the reason of the cough and to somehow think what may happen in 1 or 2 weeks time. So this is typical image not of COVID disease, of interstitial pneumonia, which we've already known because COVID has started due to, for example, flu. The thing is that we need to be somehow familiar with those connections between auscultation, X-ray, and a sonographic examination. Because if we go to the PubMed and if we look, for example, for a publication, we can see that it's very lot of work about comparison, computed tomography to sonography. Nice work, really, it's nice to read it. But actually, when we are primary physician, we don't have a choice. We have auscultation, sonography, and we don't have computed tomography. If I had computed tomography, I would give it to my patients. But if anybody with suspected pneumonia really should have computed tomography, I don't think so. So let's try to not think about what is better, who has better sensitivity and specificity. Is it computed tomography or ultrasonography? No, let's leave it. Let's think about what we can get and what we can give to our patients performing lung sonography. And I wouldn't call lung sonography another imaging technique. I would call it examination to see. The question is not to see or not to see, but the question is how to treat. In the end of the examination is not what I see, but in the end of this examination is how should I treat the patient. The lung sonography is the decision-making examination. The simplest, the one of the most simple example is dyspnea in adult patient, as we can see here, the adult patient who has both chronic obstructive pulmonary disease and cardiac insufficiency. And we are wondering what is the reason of the dyspnea. If it is exacerbation of COPD, we will see A lines. If it is due to cardiac insufficiency, cardiac failure, we would see a B lines, and this will guide us in our further diagnosis. But imagine the situation. As usual, you are at home visit. You are holding with you your stethoscope to auscultate, and you've got your modern mobile stethoscope, sonographic device. And the patient has chronic obstructive pulmonary disease and cardiac insufficiency. So he said that he has a dyspnea. You auscultate this lung and you see that when the patient is breathing out, it's getting a little bit longer. So you might think it is due to obstructive disease, but you just put a probe on it and you put on the right hand side and the left hand side you have B artifacts, but look at the pleural line, which is quite smooth. It's not interstitial pneumonia. We are looking at pulmonary edema. Even in the early stage of pulmonary edema, we might hear in an artificial stethoscope that the breathing out takes a little bit longer than breathing in. So we are during the home visit. We have our stethoscope. I am not a cardiologist, but I have ultrasound device. So what I do? Not testis. The answer is not testis at the moment, yeah? Okay. Where will I put my probe? Heart. Is it sick or he is ill? Should stay at home, should go to the hospital. Simple. What you do? It's fluid in pericardium. He should go to the hospital, yeah? And this is how it works actually, yeah? You know where you are starting, you never know when you will be finishing. This is example of adenocarcinoma of the lung. This is the lady who was losing on weight. This is how adenocarcinoma of the lung looks like, because very often it's connected with chest wall. But remember that we might have 3 parts of sonographic images in patients with lung cancer. Absolutely normal sonographic image. We can see, like in case of those adenocarcinoma, a tumor in the lung, and we might see, as in this case, B lines when the tumor is not exactly connected to the chest wall, but is changing the lung between lesions at the wall. Anyway, you are sitting in your examination room. The lady with chronic obstructive pulmonary disease is coming to you, and she said, "Doctor, I have taken all my medication I have, and I still have a dyspnea." So you auscultate the patients. You don't see the difference. You don't hear the difference between left and right side. You don't see anything which gives you to the idea of pulmonary edema. So what you are doing, you ask the lady to lie on her back and put your probe in the highest place of the chest wall, and what you can see here, is it lung point. This is pneumothorax. We can see the difference. You look at the line, we can see a line, so we know that the air is below the pleural, and you can see sliding artifact on the left-hand side and no sliding artifact on the right-hand side. And this is the place where you can find lung point, and you may think that this lady had a pneumothorax, and that was this situation. Sometimes it's not so easy. This is a man who came to me and said he was shaving himself and he suddenly feel a pain in the chest on the right hand side. So we couldn't find actually the lung point, but we could find a difference between a seashore sign or a barcode sign or a stratosphere sign on the left hand side, and it's also pneumothorax. M mode will help you to deal with in a case you suspect pneumothorax. Remember to place your transducer between the ribs. Cough, a little bit of a dyspnea, fever, you osculate the patient, you know where you want to put the probe, you put a probe on it, and what you can see? Sign sonographic image of community-acquired pneumonia. You put your Doppler in, it's not a tumor, it's typical image of community-acquired pneumonia. Let's leave it with transducer for a while, and let's take a linear transducer. The same patient, the same examination, and you can see the bronchogram here, the tiny hyperechoic spots that are moving on and in when the person is breathing. We have very good sensitivity in diagnosis of community-acquired pneumonia in adult patients and in children. But the thing is that in children especially we are able to find very tiny lesions which they don't exactly need a treatment with antibiotic. And please make sure that on the one hand ultrasound will show us the consolidation which cannot be visualized with X-ray. So don't compare the sonography with the X-ray because it does not as much sense. On the other hand, let's remember that especially in our elderly patients, pneumonia is often very misleading. Without a fever, without a cough, it might have only, for example, mental temporary retardation. Lung sonography, it's not about racing with computed tomography, what is more specific. It's about clinical decision making. And the future of lung sonography, because honestly, I think that lung sonography is the most frequently performed examination by primary physician. The goal that we may achieve with sonographic examination of the lungs is to reduce unnecessary antibiotic prescription and increase effectiveness of general practitioners to reducing a number of total visits. There are now ongoing different studies which can evaluate the value of sonographic examination in prescription of antibiotics in a field to reduce unnecessary prescription of antibiotic. And sonography of lung, it's an answer of increasing antibiotic resistance, it's increasing effectiveness of health care in outpatient department, and demographic changes and multi-diseases, and the fact that our population is getting older and the same diseases in older age have different clinical manifestation. We need coordinator education of primary physicians, education how to avoid potential pitfalls and mistakes. I will encourage you to join classical osculation with sonography of the lung, and in the end I will encourage you to visit EUROSON.pl, which is Polish website. It's in Polish actually, but you can open it in the most common Google browser, changing English language to go through the cases which we have there, because actually they are mainly from the primary care department, and they are mainly the cases which really change our management with our patients. Thank you very much.
so we came to the end of the second day of the part of the theoretical lectures, and we went today through many organs, and then I calculated that still some organs have been left. I think that next time maybe we will learn a little bit more about musculoskeletal ultrasound, about joints, how to diagnose DVT, veins, etc. So there are, although we saw a lot of organs, the human body still have enough for us for the coming years. So let us see a little bit of what we had today. So again, as yesterday, a very busy program. We started in the morning, it was today, we started in the morning with Peter, a family doctor, that gave us some practical daily used ultrasound test in his clinic. He shows us his beautiful clinic and how he is putting the examination bed as part of his daily working. And also he focused on the differences between primary care or generalist ultrasound and the ultrasound that is done by radiologists and specialists, and which is a very important topic because it should be clear that we are not replacing the ultrasound specialist, but our orientation is totally different. And it is important when you are coming back to your countries to clarify this issue and try to cooperate with the ultrasonographists, which I can say in my country is quite difficult. And then he gave us another two examples, one about the urinary bladder, is it full or not, with a mobile ultrasound, and another examination of the lungs. He also gave us a scheme of how should we organize our clinic in order to incorporate ultrasound to our daily working. And then from I would say the ordinary family doctor, we moved to the higher scale of the European organization about guidelines, etc., which are very important to standardize our working. And we talked about cooperation between organizations and also with the critical and important work of writing those guidelines, which are built partly on the literature and partly on consensus where the literature is missing or is not enough. So those guidelines are very important and we have to follow them on our daily working. And then, as we said, we are moving to Mihai. We talked about research in thyroid ultrasound, a new software that helps you to make the right decisions, and also again a very complicated issue that it will take time before it will be relevant to most of the family doctors, but we try to organize it in a very systematic way of how to do the test and how to report the results of the test, and maybe to use an artificial or an algorithm to give us a more precise direction to the diagnosis. And then we moved back to Peter, and he talked about how to use a point of care ultrasound in emergency situations, which are real emergency or even urgent situation in the ambulance. And he focused about 4 issues: how to evaluate dyspnea, how to do ultrasound during resuscitation, which was quite a challenge even to listen to this method, and about patients in trauma and in shock. And I can tell you that those measures in my home city, in our hospital, they are using all those methods in the emergency room, and I'm not sure that it is so relevant to our clinic, but out of hospital emergency services, it's really relevant to know and to be qualified in such measures. And then we came back to a breast ultrasound, and Dr. Dana Stotian gave us another lecture about the methodology and about the findings that we can find in the breast. Again, the radial method and some findings that, again, clarify us how the BRADS criteria and calculation is done, and some other findings. Then again, we moved to the breast elastography, which means that, nowadays ultrasound have multi-dimensional options. It's not only the old two options that we know, and elastography, as I understand from this meeting, from this conference, will be a part of the standard ultrasound evaluation in the near future. So, and it gave us a wonderful example how elastography help us to differentiate between benign and malignant tumors. But at the end, when we saw that the pressure makes the difference, I was a little bit worried because, if you are not qualified enough, then you can produce a lot of false positive and negative results. So this elastography is not only the machine, again, it's also the operator, which is very critical. So again, to practice and to do only things that you are qualified in. And then we moved to another organ at the testicle, and we looked for a very specific problem, very specific area of the diagnosis of small, maybe incidental findings in the testicle. And again, it is a very narrow area, but again opened the window to the testicle ultrasound. And of course, there are other very simple things that we should learn as family doctors to diagnose varicocele, to diagnose epididymitis, etc. Things that maybe are relevant for us and also needs another training. So at the end, every short lecture that we get open the window for a wide area that we should go deeper inside. And again, the same is about advances in liver imaging. We see the B mode, the Doppler techniques, the contrast enhanced ultrasound, which again, for me was a new technology in such a wide usage. I know about it, but not that it is so common. And we saw some very beautiful examples how this contrast enhanced ultrasound makes the difference of the diagnosis and make it even to spare the need to do a CT scan. And this is another technology, again, that makes the diagnosis of liver and hepatic findings more accurate. Then we go back to, we moved to the abdomen, and I know it's very difficult for us to move from one organ to another, other technologies, and then again we saw some very practical examples, for example, occlusion of the small bowel and the differentiation between paralytic and active occlusion, which are very important and very practical in our decisions. And unfortunately, because I was doing the lecture online, I was not able to introduce some photos to Mateo. So I'm sorry, Mateo. Apologize that I didn't introduce photos because it was the last lecture. But we saw very good examples, and I think again that our short memory is enough. That we can remember those images because it was the last lecture. So we saw very good examples for findings in the chest wall, pleural effusion, and also again lung sonography, which is very, very practical and important in family medicine. So I'm going to my subjective conclusion of this conference of the theoretical lectures. As I said last year, that primary point of care ultrasound is the future. I can say now it's the near future, or even maybe the present. And it should be clear that it is a very important adaptive, or even it replaces the traditional physical examination. We should continue with training. You know, it's only now such a meeting. It's only the beginning of the training. It should be standardized, and I say it also should become mandatory. Not only if you want to do it, it should be the standard in our specialty programs. We need research. We saw here during those 2 days few examples of research, one from Mihai and the second the group from Israel, that show us that artificial intelligence may help us in our daily practice because they give us the technology that helps us, because we are not enough experienced, and for sure, the more and more organs that we will do ultrasound, the less we will be experienced. So such research and such advanced in artificial intelligence may help us. We need guidelines, for sure. We need cooperation between organizations. We need regulation, and we need to find a way, although the cost of the machines is going down. In many many healthcare systems around Europe, we are dealing with clinics that are managed and handled by the family physician. And even though the cost is going down, it still may be a substantial burden to a single physician. And we also have to find ways and to be creative, maybe like leasing options, etc., with those new technologies in order to assimilate it to our daily life. So I can finish this part in saying that I hope to see you all and many of your colleagues next year in the 4th POCUS School. Thank you.
I will try to put in the daily practice what I already showed you by technical and theoretical point of view. Here are my disclosures, and this is my outline. In this lecture, I will focus mainly on thyroid, salivary gland, and testicle application. Again, some small remarks just to remind you the different techniques. Also, remembering to each of us what are the measurements that have been provided and can be provided. And also, I will try to show you what is the evidence between the two techniques that we have right now. Again, remind to everybody that you have to follow and to select the right polychromatic scale, then the right polychromatic box, look at your qualitative indicator, put the ROI, one within the lesion, another one with entire tissue, try to avoid artifacts. And at the end, you would obtain a proper measurement. There are several different quality indicators. At the end, any kind of organ you explore, you have to reach the right, balanced, harmonic, precise compression. About shear wave, also you have to be aware that pre-compression or vertical artifacts should be avoided in order to obtain quantitative evaluation by means of point shear wave, 2D shear wave, and 3D. First example, thyroid nodule, taller than wide. However, we put ROI and the velocity was within the normal range. Again, different modes of visualization, and again, importance of qualitative indicator that really can help you to obtain the best results. About some specific organs, VIENNA provided specific guidelines and EFSUMB provided our personal guidelines. I was honored for thyroid to be part of both the guidelines. And let's start with thyroid. First questions that I will try to address during my presentation. Fine needle aspiration is still the gold standard, and TIRADS, the acronyms that stands for the classification and the imaging reporting that we are trying to include in our daily life is useful. What about ultrasound, elastography? And I will try to address this issue starting from what we usually do in the daily practice. We start with baseline ultrasound. We identify nodules, we measure them, we report, and we describe echostructure, the presence and the characteristics of contour and limits, the evidence of peripheral halo, that is a benign sign, especially if it is complete, symmetric, and not thickened and irregular. The appearance of taller than wide, that corresponds to the increased vertical growth and the vascularization. Here I summarize for you the ultrasound features, starting from the more worrisome one, irregular and ill-defined borders, as clearly shown by this example, the presence of microcalcification, the presence of hypoechogenicity that you have to compare with the surrounding muscle structures, and if they are isoechoic, you state mild hypoechoic. But if it is more hypoechoic than muscles, then you can really say that is a worrisome sign, and it is markedly hypoechoic. Halo sign, clearly visible, the mixed content of the lesion, the oval-shaped appearance, the mild hypoechogenicity compared with the muscle, the marked hypoechogenicity compared with the muscle, the taller than wide appearance, and the colloid with comet tail artifacts. However, how much accurate have been reported to be this kind of signs? Looking at literature, we clearly can state that not single sign is enough accurate to characterize thyroid lesions. Horvat and other colleagues proposed to put together single ultrasound features in order to grade and to stratify the malignancy risk of these nodules. Unfortunately, in the literature, there are really several tyrants classification, and still they are not used, or rarely or not frequently used is better to say, and still tyrant nodule finding aspiration is considered gold standard. However, we are also aware about false negative and false positive rates that can be encountered in your clinical practice. Again, how we may characterize nodules using ultrasound elastography. Ueno Ito produced the 5-color scale-based classification for breast. It was mutated to thyroid and modified by Baltelli in 4 grades. Typically, when a lesion is benignly appearing at the baseline, it is completely elastic at elastography. Look at the color and the corresponding feature. It is clearly, easily characterized as benign. Vice versa, conversely, when it is very worrisome and it is very stiff, it is clearly characterized as malignant. But if I ask you, how do you rate this lesion? Some one of us would say 3A, some others 3-4, 3B, or 4. And unfortunately, the first one is corresponding to soft lesion, the other one are corresponding to malignant, and therefore to stiff lesion. Other technique, carotid pulsation based, such as quasi-static technique. And together with other experts in the literature, we proved that also this technique can achieve accurate results, but with different cutoff values compared with other techniques. And this is really the Achilles tendon weak point of our examination. Again, you see this case, then you decide to have the volumetric representation that someone of us showed that can be useful for treatment evaluation. This was the beginning of the application of ultrasound elastography. Thereafter, we tried to quantify measurements to be reliably available and allowing us the possibility to follow up this kind of patient. And to do it, we needed something else. Therefore, we put 2 ROI within lesion and the thyroid tissue, obtaining striate ratio. And my group was one of the first to find out that we will have, with any kind of equipment, a different cutoff. When you approach to any kind of techniques, you have to be aware of the possibility, but also on the limits, as I showed in my previous presentation. Again, just to remind to you some possible pitfall corresponding to tensive cystic areas, grossly calcification. In those cases, I would recommend not to apply ultrasound elastography. Be aware of artifacts, use them to confirm the baseline benign appearance. I tried to summarize some tips and tricks. You have to have ROIs of same size, including the whole nodule, or at least the major part of the nodule, and the corresponding thyroid tissue. Try to be consistent with your examination, and you have to be aware that the ROI should be maintained within the lesion during the whole examination. Then you have to use the right amount of gel, ask the patient to maintain very, very superficial breath. With share wave, similar indication, similar recommendation to obtain a reliable examination. And I would like to remind to you that vertical artifact is still a limit. And although you don't compress, you may sometimes press too much. In the literature, most of the papers favor the use of ultrasound elastography. And another important question is, at the end of the day, what is the best technique that I can use to obtain more accurate results? I recently published, together with my colleagues, this paper trying to address what is the best technique between strain elastography and 2D share wave. And I show that with my equipment, it is quite better strain elastography than share wave, as it was confirmed by this meta-analysis, and even more recently by our meta-analysis, showing that qualitative or semi-quantitative are really rivaling, but are for sure better than share wave. Typical possible daily life case. The lesion is mildly hypoechoic compared with the other thyroid tissue. There is an asymmetry of the halo sign. Finding the aspiration showing determinate results. The patient was scheduled for surgery. I did repeat the examination by means of different tools, 3D color Doppler, 3D SMI, and then I put ROI. I reevaluated by strain elastography, soft, share wave with contradictory results. But at the end, this case was proven to be benign one. Conversely, worrisome case, markedly hypoechoic, some microcalcification, better identifiable by means of a specific software called the MicroPure, color Doppler, SMI, 3D representation showed an irregular asymmetric vascularization. Strain elastography, the lesion is completely blue. Blue corresponds to heart. Strain ratio showing values higher than the cutoff value and confirmed by share wave, both the techniques. Another case that was not completely worrisome at baseline ultrasound. Color Doppler does not show typical and significant or asymmetric vascularization, but at strain elastography, the lesion appears stiff, confirmed at the strain ratio, confirmed at share wave, also using 3D multiplanar reformation that also can help you to better identify the irregularity of the margin, and this was approved papillary carcinoma. We published also an editorial with my friend Michael Bachmann-Nielsen and Ferdinando D'Ambrosio, showing that there are some still open issues. What is the most accurate and reproducible elastographic technique? Although right now, in this moment, we are still favoring strain elastography. What is the role for indeterminate nodule? Although we prove it in several papers that can be useful to increase accuracy by at least 10%. How much reproducible is the technique? However, recently, thanking the qualitative indicator, now it's better and it's easier to obtain good results. And also still, we don't know how much thyroiditis can influence our examination. However, if you look at the guidelines, we included in the daily workup elastography, and recently European Association of Thyroid Disease included as a possible additional tool in the daily life. We need to reduce fine needle aspiration. We need to use unnecessary thyroidectomy. Thyroids is very useful, but we have to obtain a universal consensus, including also elastography. Also, trying to follow up patients who are conservatively treated or are minimally invasively treated. What about salivary glands? We have some statements already. If you see a lesion that is infiltrative, that has a really worrisome appearance at baseline, markedly hypoechoic, characterized by chaotic vascularization or hard pattern elastography, be aware, this could be malignant, although they are rare. But what was really important is to try to use these techniques to differentiate really benign lesion, worting tumor, from benign but possibly malignant transformed lesion, pleomorphic adenoma, that can also change in their natural history its appearance. We know that we have to deal with some risk factors, ionizing radiations, employment one, genetic factors, smoking, and we know also what are the different benign or malignant entities. Here are the most frequent that you will encounter during your daily life. And I underline it for pleomorphic adenoma that there is a risk of 5% to undergo malignant transformation. Parallelly, Wortings tumors more frequently are bilateral and multicenter. The issue is to differentiate, to reduce fine needle aspiration that sometimes in a range between 5 to 10% is not accurate. How we can do? I suggest you to download this paper. This is a CME paper that I published some years ago, showing the background, clinical background, histological background, therapeutical background, and ultrasound and MRI features of all the different entities. EFSUMB guidelines still does not recommend to use ultrasound elastography. VIENNA guidelines still not dedicate any kind of guidelines about this. We know also that we have the possibility to use PoC-US. PoC-US provides to us morphological and quantitative analysis. And we publish also our experience trying to show what are the specific features that can help us to better differentiate worting tumor that I anticipate to you is more vascularized than pleomorphic adenoma and is softer than pleomorphic adenoma. If you put together these features, you obtain the multi-parametric evaluation. Here is a typical example with not highly vascularized lesion, and this was a pleomorphic adenoma. This is the diagnostic algorithm, and what we want really is to reduce fine needle aspiration and combine multi-parametric